Okay. Assalamu alaikum. Peace be upon you all in Arabic. Thank you for joining us today. My name is Ibrahim Amar. I'm a medical student. I go to King Saud bin Abdulaziz University for Health Sciences in Jeddah, Saudi Arabia. Thank you for joining another Rafael Medina subspecialty VMR. Today's subspecialty VMR will be dermatology focused. We'll be hosting Dr. Abdulhadi Jfri as well as Dr. Asma Zeidan. Dr. Abdulhadi Jfri is an assistant professor of dermatology at King Saud bin Abdulaziz University for Health Sciences in Jeddah, Saudi Arabia. He's completed his dermatology residency at McGill University in Montreal, Canada. During his time at McGill, Dr. Jfri has completed a master's degree and has been the assistant chief resident and chief resident. He's completed not one, but two fellowships, an advanced surgical dermatology fellowship at Sinai Hospital, New York, and a complex medical dermatology fellowship at Brigham and Women's Hospital, Dana-Farber Cancer Institute at Harvard Medical School, being the first non-US IMG to ever match and complete the said fellowship. So Dr. Abdulhadi, thank you for joining us today.
Thank you so much for the invitation. I'm so excited for this session.
I think everyone in here is actually excited for the session, but would you be able, Dr. Abdulhadi, to introduce yourself to the audience and give them a one-liner about you?
Okay, so guys, I've just actually returned back to Saudi Arabia 1 year ago, and I'm working in a hospital. It's actually a teaching hospital. I do more complex derm, advanced cases, GVHD, cancer patients, and all the other general derm stuff. I teach at the College of Medicine, and I work in a private practice where I do mostly cosmetic, filler, Botox, all these laser stuff. Yeah, so I like it, and I miss my training and studying and everything. And today, it actually brings flashback from my Royal College derm exam where we had 20 stations on 20 cases. So hopefully the case that Asma will present today would not be so complicated. We'll see.
No, I think we had a lecture from you a couple of weeks ago, and I'm pretty sure you're gonna get the diagnosis from the chief complaint, so no worries at all.
Okay.
So Dr. Abdulhadi, would you please be kind enough to share with us why you went into dermatology?
So I honestly didn't know why I like dermatology, but I am always a person who loves, I don't like boring stuff, to be honest. I don't think there are boring specialty, but I don't like, just reading labs and seeing blood sugar and adjusting insulin. And I paint a lot, so I like visual arts. So when I was actually a med student, I did 2 electives. I did one at McGill where I matched for residency, and I did one at Harvard where I matched for fellowship later on. So the staff at Harvard told me, where did you go during the weekend? And I was like, I went to the museums of arts in Boston. And she goes, oh, you like visual arts? That's actually why you like dermatology. I was like, really? Okay, perfect. She goes, you know what? Just try to write your personal statement based on that. And we actually created a story from that. So I feel, yeah, maybe my love of visual arts is connected to my love to dermatology. And, I don't like to see, because things look different on different skin colors and they're not always presenting the same.
Yeah. Well, that's so interesting. Thank you for sharing that with us.
I would like to know why Asma went into dermatology. I never asked her this question before.
Well, now's the time, Asma. So Dr. Asma Zeidan is currently a dermatology resident at King Abdulaziz Medical City in Jeddah, Saudi Arabia. She's graduated with first-class honors from King Abdulaziz University. Dr. Asma, can you introduce yourself to the audience and give them a one-liner about you?
Yes, hello everyone. I hope you enjoyed today's case presentation. I am R3, currently dermatology resident in National Guard Hospital. Dr. Jeffrey, I entered dermatology because I like challenging specialty, and I think we did not experience derma during medical school, so it was a new specialty, and that's why.
Well, thank you, Dr. Asma.
Usually their teaching during med school is not, extensive, just like 2 weeks, maybe a few lectures here and there. So that's
agreed.
All over the world, that's, I think, a global thing.
Right. Agreed, 100%. So Asma, can you tell us a little bit more about how your derm residency program is structured?
Well, it's a 4 years program. Usually the first year we're not in dermatology rotation. We usually take medicine for 7 months and 3 month pediatric rotations. After that, the rest of the 3 years we only stay in dermatology.
Okay, that's interesting. So I think now we'll start with the case. So thank you
Okay.
both, Dr. Abdulhadi, and thank you, Dr. Asma. So Noah, if you can share your screen, please. Okay.
I think no one needs to be a co-host to be able to share this screen.
Yeah. Okay, Dr. Asma, you can go ahead.
Okay, so this is a case of 45 years old male patient presented to the ER complaining of bilateral lower legs painful rash for 2 weeks. So, Dr. Jfri, what would you like to know from the history?
I mean, this is not super acute and not super chronic. It's like a subacute 2 weeks history of painful lesions, both legs. I have a lot of questions. I mean, I want to know if the patient has, we have rashes that are painful and rashes that do not do itch or have no symptoms. So this
Yes.
falls in the category of painful rashes. So I want to know if the patient has any medical diseases, takes any medication, or actually started recently new medication. I want to also know if the patient has any rashes anywhere else on the body, and also if they're having any other symptoms, like systemic symptoms. I want to know also what did the patient do during these 2 weeks for the pain? Did the patient try to apply anything on the skin or take anything for the pain? Did what increased that rash, decrease? Is it the same, started 2 weeks ago and remains the same, or it's progressing, getting worse, and getting worse in what format actually? And then I want to also know if the patient had any previous similar episodes before, or this is the first time. And other things I also want to know if the patient is a smoker, if there is any family history of similar skin lesions as well.
Okay.
One thing I need to point out, in dermatology in real life, we look at the patient. I know in med school, we learned that we have to take history, but in dermatology in real life, show me your skin, and then we gonna, talk about it.
Yeah, another plus point for derma.
So Dr. Abdulhadi, I was just wondering, how do you usually teach your residents? If someone, for example, called you and they were on call at 2 a.m., how do you usually teach your residents to actually describe certain skin lesions to you over the phone?
So usually I don't have issues when I get consulted by derm residents because they're trained, very well trained during their first year on the skin morphology to differentiate macule, papules, and purpura. Is it palpable, not palpable, reticulated lesions, livido reticularis? So they usually give me the right keywords. But it's a difficulty when we get consulted by other specialties. Sometimes they don't describe it well on the phone, and we may need to see pictures if we have the availability of seeing, some visual images. But again, sometimes it looks different in real life. So we like to touch the skin, look at the patient. But I agree with you. It's challenging sometimes to give the right description over the phone. But from derm residents, usually I don't have issues.
So, so this is actually, these are two images that Asma has shared with us prior to this session. So how would you go on describing these lesions that you see on the screen?
So the ones on below the knee, on bilateral legs, I would say there are multiple purpura. Just to give anyone a brief differentiation between petechiae, purpura, and ecchymosis, we don't usually go and measure it on the skin. The smaller one is usually petechiae and then purpura, and then the larger one are usually ecchymosis. Like this one on the ankles, they're like more into the ecchymosis category, necrosis, ulceration. But on bilateral, the majority of the lesions are purpura to me. I do see some areas of erosions or ulcerations, and the dark areas are usually necrosis, skin necrosis. So this is what I'm seeing on the scan.
Okay, and then when you actually see something like that, before hearing more about the HPI of this patient or their past history, do you tend to have a list of differential diagnoses just based on that? And what makes you think of one diagnosis more than the other?
That's a good question. So because dermatology is very visual, we have something called Gestalt diagnosis. So Gestalt is like, because I've seen so many cases and just looking at this, my gut feeling is it's one of the things that I've seen a lot versus systematic approach. Systematic approach is like, go what kind of lesions I'm seeing, the primary lesions. So the primary lesions in this case is purpura. And if it is bilateral, usually we can go with vasculitis. And then my Gestalt diagnosis would make me think about medium vessel, to small vessel, like, because I'm seeing ulcerations, necrosis, so that makes it more small/medium vessel vasculitis, versus if I just only seen the ones on the upper legs, I would just think about small vessel vasculitis. One of the important things is I want to touch these lesions, because if they're palpable, that will make a difference. That will make me think of vasculitis if these lesions are palpable. But if they're flat, then we'll think about something related to the patient underlying thrombocytes count. It could be just, a petechiae or a bruise more than an actual palpable purpura. That is a key word for vasculitis. The presence of the ulceration and the necrosis is an indication of the blockage of these blood vessels that, when you cut the blood supply from one area, it's going to necrose. And when it's necrosed, it's going to ulcerate and slough off. That's, a normal natural history of vasculitis if untreated. And I believe this has been going on for 2 weeks now. So, yeah, so that's usually my top diagnosis. We are talking or in the vasculitis category. And then I divide them, in my head. I usually divide things into categories. So I have inflammatory, infectious, neoplastic, drug-induced, and then genetics. These are the 5, categories that I have in my head. And under each category, I will put a differential diagnosis.
Okay. And then if I heard you right, Dr. Abdulhadi, you mentioned that there are specific types of skin lesions that occur in small vessel vasculitides versus medium versus large vessel vasculitides. So would you be able to elaborate more on that?
Yeah, so it makes sense that, it depends on the size of the blood vessels. What are you seeing? The skin would reflect that. For example, if you're blocking a small, tiny, it's normal to see these purpura or palpable purpura because it's a small vessel. And you're going to see a scattered palpable red dots on the skin. Versus if it is a medium, then this blockage will, cut a good amount of blood supply. So you expect to see more of the ulceration, necrosis. You may feel deep nodules, and you may see a reticulation because you blocked a big area that channels and gives other branches. So that will also reflect on the skin. Maybe it's not clear in this case, but you may see something called livido reticularis if it is connected, or if it is broken, we call it livido racemosa. And then the large one, the large one usually not obvious, like Takayasu or giant cell temporal arteritis here in the temporal area, so that you will see a very bulging blood vessels. So that would be a palpable blood vessel. But the aorta one, you're not gonna see the aortitis, the big one, you're not gonna see anything on the skin. Basically, it's an internal thing. You may see differences in the pulse between the right and the left, but it wouldn't be obvious on the skin.
Thank you, Dr. Abdulhadi. So Asma, maybe we can move now on to the HPI of this patient.
Okay, so he has history of fever and myalgia for 7 days. He's also complaining of cough and shortness of breath and wheezes for 4 days. He also has numbness and weakness in both hands and feet for 4 days, difficulty in holding an object with his hand, and difficulty in walking. Other systematic review were unremarkable.
Okay. So thank you, Asma. So based on that, Dr. Abdulhadi, what makes you refine your list of differential diagnoses, and what makes you specifically take a specific look into?
So based on HBI, we haven't moved on to the other part of the history, but just based on what I was giving right now, I'm thinking about a couple of things. One of it is basically would be an infectious. We can have a reactive vasculitis with an infection. That's a common thing. The other thing, if the patient has like fever and myalgia and the cough, like for example, pneumonia, then I would think about if the patient took any antibiotic recently or painkillers, that will be drug-induced vasculitis. But what doesn't go with that is having neurological symptoms. So that's a bit unusual. I mean, there are rare entities of vasculitis where there are associated peripheral neuropathy. So that would be one of them, like the ANCA vasculitis, especially with if the patient has this shortness of breath and wheeze, but it's only for 4 days. Usually those patients would have it for a longer period of time. There would be no like allergic rhinitis or asthma, for example, before the vasculitis show on the skin. So that would be another differential in my head. So
Right. And you've mentioned, Dr. Abdulhadi, that sometimes you can have a reactive vasculitis secondary to certain medications. So what kind of antibiotics should typically ring a bell for you when seeing such a patient?
So, all medications, if you look at the list of the small vessel vasculitis reactive ones, you're going to see penicillins, cephalosporins, any kind of antibiotic would actually could lead to reactive small vessel vasculitis. But the infection itself can also lead to that. So it's really hard to differentiate clinically whether it is the infection or the medication. Of course, if the patient did not receive the medication and has vasculitis, that will go with infection. But if they both appear at the same time, well, the patient got introduced into the antibiotics. So sometimes it's hard and you can't tell by the skin biopsy. But we do have certain medications that can induce something called ANCA vasculitis. So that would be something like minocycline on top of the list, or the anti-thyroid medications such as propylthyroid. Yes, exactly, asthma, and then methimazole. We can think about the hydrazine, methyl-duba, anti-seizure medication, phenytoin. I mean, there is a big list.
Mm-hmm. Okay. So thank you, Dr. Abdulhadi. So Asma, maybe we could move on to the next aliquot.
Okay, so for the past medical history, he's known to have recurrent allergic rhinosinusitis. He also underwent sinus surgery 2 years ago. He's currently using only salbutamol and montelukast. He has positive family history of atopy. He's a retired soldier and lives with his family. He does not drink or smoke. He has only seafood allergy.
Okay. So thank you, Dr. Asma. So Dr. Abdulhadi, based on this aliquot, I'm seeing atopy, I'm seeing sinusitis. Does that typically make a difference? Or would it be something that you wouldn't really rely on when approaching such a patient?
I mean, it could be a coincidence that the patient has, atopic triad where the patient would have allergic rhinitis and the asthma and, the atopy picture versus, and then suddenly got an infection because of the, the being an atopic person with asthma and develop pneumonia. It's a common scenario, and then have a reactive vasculitis. But again, I'm also stressing back on the neuropathy that does not go with it. So based on that, with the neuropathy, I would think about eosinophilic type of vasculitis is rare, is not common. Like EGPA, granulomatosis with polyangiitis would be on top of the list for that presentation. And based on connecting the dots, the images, the history, the atopy. Other than that, would also think about, the other causes of vasculitis in an atopic person, basically, and maybe this peripheral neuropathy is related to undiagnosed diabetes or related to, low vitamin B, for example, I have to consider that as well. So that needs to be assessed by neurology.
Mm-hmm. Okay, and then if I think this case is leading more towards a vasculitic picture. So let's say, for example, that a resident hears this. Do you usually teach them about how to approach the examination of a patient? Do they do a full examination, or do they focus on specific parts for the time being?
Okay, so if you have a patient with vasculitis, it is really important to examine the patient head to toe. I know we're in dermatology, we're just looking at the skin, but we know we studied medicine, and as Asma was just mentioning, that the first year of her training is in medicine, and in Canada, the first 2 years of my training are in medicine. So we need to examine the patient fully, because the blood vessels are present everywhere, and especially if it is small or medium, it's everywhere. It's in the heart, it's in the kidney, it's in the GI system. So we need to make sure that the patient doesn't have any systemic involvement, because vasculitis, just going back to the classification, is it a skin limited disease only, or is it a systematic disease, or it's a systemic disease with some skin involvement? So again, the blood vessels are everywhere. So head to toe, look at the eye, skin around the eye, look in their mouth, see if they have any sore throat, palpate their lymph nodes, see if they have an infection, auscultate their lung, heart, and then look at the abdomen if there is any abdominal pain, and then kidney for bruit, for example, and then full skin examination head to toe that includes the mucous membrane. And on the skin, when you see these purpura, try to palpate them to make sure. I tell them, close your eyes and rub your hand on it. If you feel something, so this is palpable purpura. If you don't feel anything, that's flat. And then look to see if there are any ulcerations, any necrosis, the retiform purpura that we talked about, the livido reticularis, livido retinosa, examine their nails, their mucous membrane as well is important. It's part of our dermatology. A lot of specialties think nails and hair and mucous membrane are not part of our specialty, but it is. And we need to examine them in the patient as well. And of course, neurology would not, I have to say, as a staff, sometimes we forget how to, examine the joint and use the hammer for reflexes. But it's part of the exam, and we need to try our best to see if the patient has any abnormal movement, weakness, muscle weakness, and then examine their peripheral sensation to make sure that they don't have any, loss of sensation like neuropathy, which is something we have here in the case.
And so, Dr. Abdulhadi, I think you've mentioned the peripheral neuropathy, and you've also mentioned the CNS manifestations or the PNS manifestations that patients can sometimes have. So is there something that is pretty urgent, something if you hear that is happening in the ED with a patient who's coming with a picture of vasculitis, that makes you do something urgent for them before they deteriorate, or do you usually wait until the final diagnosis?
Of course, there are a couple of vasculitis that can happen in association, nerve involvement happens in association with vasculitis, such as mononeuritis multiplex. I mean, if you treat it early, of course, the nerve damage is something will take time to heal or sometimes may not heal. So you want to interfere as soon as possible. And delay in treating nerve involvement will lead to long-term consequences. And then polyneuropathy as well. The thing is, it's a vasculitis. So it's a blood vessel that supplies the nerve. And if you cut the blood supply to the nerve will not function anymore. The other thing is temporal arteritis is one of the important things that can actually lead to blindness. So that we need to interfere. It's not the type of vasculitis we're dealing with here in this scenario, but it's something you need to interfere early with systemic steroids to prevent blindness. Yeah.
So thank you so much. So Dr. Asma, maybe we can move on to the next aliquot.
Okay, on examination, his temperature was 37.9. The other vital signs were within normal ranges. General examination, he was alert and oriented. He looks ill. Head and neck examination was normal. Cardiovascular examination was normal also. Pulmonary examination, he has respiratory distress and bilateral expiratory rhonchi. Abdomen was soft and lax. Neurological examination revealed bilateral asymmetrical distal muscle weakness with sensory loss and loss of deep tendon reflexes, except the biceps reflex. Examination of the skin showed bilateral lower legs palpable purpura with overlying multiple necrotic punched out small ulcers.
So, Dr. Abdulhadi, I think what I can see here is mostly pulmonary involvement. So, how do you approach such a respiratory involvement in a patient with a vasculitic picture?
So this patient needs an X-ray, and also we need, so in the clinic with a patient with an active vasculitis, if there is any lung symptoms, I would start with the chest X-ray to begin with, just to make sure that the patient doesn't have any source of infection, like a pulmonary infiltrates that goes with pneumonia or fluid, that obliterates the area of the lung and gives them picture of pleural effusion, or if there is any opacities that can also go with what we're thinking here. Eosinophilic, usually they have migratory or transient pulmonary opacities. And of course, you have to stabilize the patient. If the patient is rest distress, make sure that the patient has a normal oxygen saturation, consult pulm if needed. That's from our derm part.
Right. And then if this patient would be having a pneumonia as part of their infection, or would it be something that's related to their vasculitic picture?
It could be both. The patient could have a pneumonia as an infection, pleural effusion as a consequence of an infection. And we know that we divide pleural effusion based on the cause. Or it could be just a pleural effusion due to infiltrates from the eosinophils, if it is what we're thinking about. We still haven't got the rest of the test and the skin biopsy. I'm so excited to know if we've done that and what we have in it. And then that's what we usually do.
And then before going on to the next aliquot, let's assume that, for example, a primary care physician sees such a case. What would you ask them to order for labs, for example, initially for a patient with such a picture presenting image?
So usually the labs that I order are, to help me reach out my diagnosis and also to rule out association with the disease. For example, I'm going to order to begin with CBC with differential, the chemistry, looking at the lights, and then I want to look at the liver profile, renal, creatinine. I want to do the inflammatory markers, CRP, ESR. Also, I want to include things that could lead to vasculitis. For example, cryoglobulins, things that can help me differentiate the vasculitis, the ANCA, PANCA, CANCA. I want to order things that commonly we see in the clinic associated with vasculitis, like he's a middle-aged man. So I want to make sure that, and also with the MSK symptoms, I want to make sure that he doesn't have RA. So I want to order rheumatoid factor. I want to order ANA to rule out lupus. And then also giving the peripheral neuropathy common could be part of undiagnosed diabetes. I want to look at his hemoglobin A1C. Things that can also be associated with vasculitis would be hepatitis profile. And that's based on the blood. And then I'm going to order something for urine, like urine analysis to look for any blood cast in the urine. Because we said the blood vessels are everywhere. So renal blood vessel involvement will show as microscopic hematuria. One of the things that I think forgot to ask is I also like to ask the patient if they have blood in their stool, blood from anywhere, because epistaxis, hematochezia, hematuria, like breakage in blood vessels everywhere can lead to bleeding. So we need to make sure that the patient doesn't have any GI involvement of the blood vessels. And then, of course, the patient has rest symptoms. So when we have a patient who is respiratory distress, we want to make sure that the patient doesn't have a cardiac ischemia. So we will order ECG as well. Plus, sometimes vasculitis can be associated with pericarditis, myocarditis, And medium vessel blood vessels is actually coronary is a medium vessel, so we need to make sure that the patient doesn't have ischemia. And for the lung, as I mentioned, we can start with chest X-ray, and we can order further tests if needed.
Mhm.
I'm talking
Okay.
too fast for whoever is typing.
Well, if Dr. Abdulhadi is talking too fast, please let us know in the chat. And hopefully he will talk slower next time. So Dr. Abdulhadi also brought up the issue of hepatitis. So would you say it's actually possible for a patient to present with vasculitis secondary to hepatitis, even if on systemic examination they don't have the typical jaundice, the typical hepatomegaly, the ascites, or would that be uncommon?
We have in dermatology a huge list of skin manifestations that are associated with hepatitis. And the list is very short for hepatitis C. So in this case, we would order the antibody for Hep C and the hepatitis B surface antigen as a screening for Hep B. For Hep B, we have so many manifestations, and it's not very specific. For Hep C, it's usually acronecrolytic erythema, something very necrotic. We can have lichen planus, usually ulcerative lichen planus in the mouth. Because sometimes if you treat the underlying hepatitis, that would actually improve the cutaneous manifestations. But sometimes it can be just an association, and it's really important to treat the underlying disease. And even if you treat it, the skin doesn't get better and needs treatment on its own. So one of the things is vasculitis itself, like just a small vessel vasculitis, can be associated with Hep B and Hep C. But what is also interesting is cryoglobulins deposition, type 2 and type 3, that is also associated with hepatitis, like B and C, and can also manifest as vasculitis. Yes, they may have more of acral necrosis, like they have necrosis on their ears. And if we see necrosis in the ears in the medicine, we think about cryoglobulin, we think about levamisole tinted cocaine, if the patient sniffs cocaine, and it's usually a type of vasculitis.
Mm-hmm. So, Dr. Asma, I think we can go on to the next autoquote now.
Okay, so his white blood cells was high, the absolute eosinophilic count was high, otherwise it was normal. ESR was normal, CPR was high, renal function and liver function tests were normal, creatinine phosphokinase was high, cardiac enzymes were negative, ANA and anti-double strand DNA, C-ANCA and P-ANCA were negative, C3 and C4 were normal, IgE level was high, hepatitis serology was negative.
Mm-hmm. Okay, so I can see that the ANCA in here, the P-ANCA was negative. So Dr. Abdulhadi, does that specifically rule out certain vasculitic diagnoses, or are the ANCA antibodies there only to help you make a diagnosis per se?
It's putting pieces of the puzzles to find the final diagnosis. So even if ANCA is negative, that does not rule the diagnosis. It would be helpful to see it positive. For the IgA, I'm not sure why do we have, IgE, okay, perfect. So the IgE high, you could see that in any person who is atopic person, and in medicine we have the atopic triad where we have the allergic rhinitis, the asthma, and atopic dermatitis, but also could be a part of the disease here. The inflammatory marker CRP is high, so that makes sense, in the setting of vasculitis. And actually, this is one of the very common tests to be high. One of the teaching points that I want you guys to remember is the single most important test in a patient with vasculitis is urine analysis, because urine analysis would show if there is a renal involvement. I'm not sure if we order, the creatinine is normal, that's perfect. So to answer your question, if we have a negative vasculitis, that does not rule certain vasculitis. Basically, it's helpful to see ANCA or P or C positive. That will make me think about the ANCA vasculitis, like microscopic cholangitis, eosinophilic granulomatosis with cholangitis, or granulomatosis with cholangitis, or the ANCA-induced drug-induced vasculitis that are usually ANCA positive.
Yep. Thank you so much for that. I think it was super helpful. So Dr. Aspa, I think we can move on to the imaging right now without saying the final diagnosis.
Okay, so the pulmonary function test revealed reversible obstructive pattern suggestive of asthma. ECG showed sinus tachycardia. Echocardiogram showed hypokinesia in septum and anterior wall. Chest X-ray was normal. Coronary angiogram showed mild single vessel disease in left anterior descending coronary artery. Nerve conduction studies were suggestive of mononeuritis multiplex. Skin biopsy showed eosinophilia and vasculitis in small to medium blood vessels and extravascular granuloma.
Okay. So hearing this imaging and the results of these tests, Dr. Abdulhadi, how does all of this refine your way of thinking?
So, it seems like the patient has systemic type of vasculitis. It's not only skin limited vasculitis. And the presence of the granuloma with the eosinophils infiltrates and the medium vessel, small medium vessel, that makes me think about EGPA, eosinophilic granulomatosis with polyangiitis, or otherwise known as Church-Strauss disease. One of important also teaching points, if you have a case of vasculitis, you have to take two kinds of skin biopsy. Just to simplify it, skin biopsy is like a cookie cutter. We cut part of the skin and we look it up under the microscope. We can do something for H&E just to give us the regular pathology, and we can do a fancy test called DIF, direct immunofluorescence. If you have a vasculitis, you need to do skin biopsy for H&E, and the other one is for DIF. And we try to take it from a lesion that appeared less than 24 hours. I know he has these lesions for 2 weeks, but we can ask the patient if there is any one of the lesions that appeared in less than 1 day. We can do that for the DIF. That will make it a high yield one. So that would be my top differential diagnosis so far, the AGPA, based on everything we have.
Mm-hmm. So let's assume, Dr. Abdulhadi, that this patient, for example, had a very typical picture of, say, for example, polyarteritis nodosa, or as you've just mentioned, what this patient has, EGPA. Do you still pursue skin biopsy, even if the picture is pretty clear and leads to a certain diagnosis?
Of course, we need the skin biopsy, and the skin biopsy needs to be deep, like taken from the dermis, because the skin, we have the epidermis, the upper layer, and the medium layer is the dermis, where the blood vessels are present. So you need to actually capture that. So take a biopsy from the dermis, and then you have the subcutaneous part. But you need an evidence that there are cells around these blood vessels. So if I see neutrophils, I'll think about the reactive vasculitis we see every day in the clinic and in the ER. Small vessel vasculitis, you just see neutrophils. Leukocytoclastic vasculitis, they rupture and they die around the blood vessels. But when we see a lot of infiltrates of eosinophils and granuloma, I have to think about this. PAN, I think it's an excellent, someone was writing PAN in the chat. I think it's an excellent thought, polyarteritis nodosa. That's usually medium and can be cutaneous only or systemic. And they also can have some systemic involvement, renal, lung. But PAN usually on the biopsy doesn't typically have the presence of eosinophils, and the patient is not very, ectopic like what we have here. And the nerve involvement as well is pretty characteristic of EGPA.
Mm-hmm. So if I hear you right, doctor, you're saying that if there is granulomas, this would lead us more into thinking about the chronic process. And with a chronic process, this would lead us away from a vasculitis secondary to infection or a certain medication, right?
Yeah, you wouldn't see, granuloma is basically a collection of cells with macrophages under the microscope. So if you see a granuloma, that doesn't mean necessarily all the time it's a chronic process, because very common thing we also see in the clinic that present exactly the same, common bilateral lower leg nodules, erythema nodosum. And this is something you guys will see in your exams. Usually they love to ask about it. So erythema nodosum, it's a reactive thing. And if you biopsy that, it's actually the third layer, the subcutaneous fat, the panniculitis. So you will find neutrophils rupturing and getting engulfed by macrophages, and that is called microgranuloma. It's a very characteristic of erythema nodosa, which it's basically, I would expect to see it on a midterm exam more than this difficult case that Asma just prepared for me.
Okay, so yeah,
very common.
yeah. So Dr. Asma, maybe you can now let us know of the final diagnosis and what you learned from this case as a derm resident.
Well, it's diagnosed as eosinophilic granulomatosis with polyangiitis.
And do you think that you've learned something out of this case?
Well, this case, we have multiple differentiations, as Dr. Jeffrey said. We differentiate based on the clinical morphology, either to palpable purpura or non-palpable purpura. So palpable purpura, we'll think about vasculitis more. And as Dr. Jeffrey mentioned, if we have like ulcers, we'll think about more small to medium vessel vasculitis. We have very large differential diagnosis. We can go from idiopathic, autoimmune, like he said. Autoimmune, we have multiple, like rheumatoid arthritis, SLE. It all can cause small to medium vessel vasculitis. We also can think about drug induced. In this case, he has taken montelukast. It's one of the drugs that can cause eosinophilic granulomatosis. And then also we can think about infectious causes and malignancy related also.
So I have this question. Maybe it's for both Dr. Asma or Dr. Jeffrey. I think Asma, you mentioned that this could be something secondary to montelukast. So in such patients whom you see presenting with a vasculitic picture secondary to a drug, would cessation of this drug usually reverse the patient's course of disease, or is it usually persistent?
So I think Asma just raised a very important point that patients who take leukotriene antagonist, such as montelukast, for example, they can have a risk of developing EGPA, but the risk is not clear because it could be that the patient already has been, the disease actually comes in stages. The EGPA is not very common, it's rare, and usually comes in stages. The first stage is having this atopic picture, sinusitis, asthma, and maybe during that period, the patient would be exposed to the montelukast. But after that, we'll get to the vasculitis stage where the patient would present clinically to us in dermatology, like what happened here. So it's hard to really say if the drug itself induced versus if it is just a part of the natural, course of the disease. I found that's difficult in the EGPA, and I agree with Asma. It's mentioned in our textbook that actually the medication is associated with the disease. I find it difficult to, to link them together. But we do have medications that obviously induce vasculitis, like the minocycline, the propylthyracil. And your question is excellent. When we stop them, patient gets better and they improve. The vasculitis just resolved. And we feel that this medication stimulates something in the blood vessels to make the neutrophils go and attack the blood vessels. And once you stop the medication, you stop the cause of the vasculitis, and the vasculitis gets better.
So in such a patient, would you say that if, for example, they presented to their primary care physician, should they probably stop their montelukast, or would that something that would probably exacerbate their atopy? Would you go for that specifically as a physician?
For me, that's question. Okay. So if the patient already have an established diagnosis for EGPA, because we do have diagnostic criteria for this disease, it's 4 out of 6. If I remember them correctly, having asthma, paranasal sinusitis, the pleural opacities, the transient lung involvement or migratory. And then if we have the peripheral neuropathy, either poly or mono, the high eosinophil levels, more than 10% of white blood cells count. Is there anything else? Exactly. So a biopsy evidence of eosinophil involvement in the blood vessels. So if we have 4 out of 6, that will make establish the diagnosis. the disease is chronic. So stopping the medication will not change that fact. Does that will influence the severity of the disease? It's hard to say. And I would just keep the patient on it if it is necessary. And again, that's not the derm decision, it's a multidisciplinary team decision. Those patients are usually taken care of by a multidisciplinary team, like rheum, neuro, derm, will be on board with Palm, of course, to decide whether we keep them or we do have alternatives.
So, Dr. Jfri, any last advice? So, a lot of people here are actually future internists, hopefully. Some of them are already residents. I believe some are fellows. I'm not sure if we have any consultants or attendings joining us today, but specifically when approaching a case that seems to be derm focused, do you have any advice for internists on how to approach them?
In general, not related to this one.
Mm-hmm.
So in general, I would just basically make sure that I don't have any red flags. So we have red flags in dermatology. If we see them, or if you tell me that on the phone, I will be thinking about serious derm emergency things. So if there is any mucosal involvement, when you examine any patient with skin rash, always look at their mucous membrane, look at their mouth, look at their conjunctiva, look at their private area. See if they have any blisters on their skin. That's also a red flag. If the skin sloughs off by just rubbing your finger on the skin, that's called Nikolsky sign. It's also a red flag. If the patient is unwell, I mean, this patient has fever, he has respiratory distress. So if the patient is systemically unwell with the rash, that also would, be a concerning case. That would
Pain
be general. Yeah, exactly. Pain. Excellent, Asma.
Right. I think Asma is ready to become an attending already.
I think we have a lot of diseases in dermatology that itch. That's okay. But pain, we have to think about something serious, a blockage of the blood vessels usually in the skin, such as in this case, vasculitis, or can be even deep in the fat. That is usually panniculitis. That will give us pain.
So thank you, Dr. Jfri. And back to Asma, I am pretty sure you've had to interact with a lot of internists within your residency. So do you have any advice for your fellow internal medicine residents?
Yeah, just don't say Steven Johnson. Not every rash is a Steven Johnson rash. And when we ask them to describe the rash, they will say they have like palm and sole involvement. So this is not Steven Johnson. This will not make us come to see the case. I think just try to describe the case. I know it's difficult to describe even for us, the dermatology resident. Yes, you can send a picture so we can see and with ourselves.
Well, thank you, Dr. Asma. Thank you for joining us today. So I think now, finally, we'll move on to the teaching points with Mohammed before ending our session. So Mohammed, you have the mic.
Yes, everyone. Hello. Thank you for the lovely case. It was a great to hear and think about such a case with a wide DDX and a train of thought, to be honest. So we started with a patient who had a rash, and we said the first thing that we should do is to identify the characteristics of that rash. So is it painful? Is it painless? Is it itching? The classic morphology description of the rash, other sides, was it the similar, is there like a similar rash that happened to the patient previously, or was it the first time? Also asking about systemic symptoms, comorbidities of the patient, which could be contributing factors. And then upon exam, when we basically palpate the rash, it's an important distinction is to see and feel if the purpura is palpable or non-palpable, because this will help us thinking about the differential diagnosis as well. So palpable purpura most likely make us think of vascular disease. And if you see ulcers as well, it should make you think of medium vessels involvement more than small vessel. And also a part of the DDX is infections, and we said we should identify whether this rash could be a reactive response to an infection, or maybe a drug related to treating that infection, or maybe a side effect of a drug that has been newly started in the patient's meds. Common drugs include antibiotics, the common ones as well, penicillins, cephalosporins, and many other medications. Autoimmune, we talked about vascularities, and we also mentioned the point about basically asking the patient if he's got any bleeding from anywhere, as fragile blood vessels could bleed anywhere, including the GI tract, the mucous membrane. So we should ask the patient about any melena or any basically hemorrhage or even bleeding epistaxis. So when thinking about vascularities, it's important to do a full head-to-toe exam with a focus on the skin and mucous membranes. And as you know, because blood vessels are everywhere feeding the skin, and infection plus rash, figure out the temporal relationship, because they're not always related. So a rash could be basically a secondary response to infection, or it could be just something else. So it's important to identify the temporal relationship between both of them. And as we ordered and the labs for this patient, so it's basically according to the DDX. So we started ordering the common labs, including CBC, inflammatory markers, LFTs, and autoimmune workup. And finally, the diagnosis was revealed to us mainly by the biopsy results, featuring a granuloma and eosinophilic infiltrate, which are characteristic of EGPA. EGPA is basically an anchor vascularities of the small vessels that is commonly characterized by eosinophilia and necrotizing granuloma. And it most commonly involves the lungs and skin. And if you notice in this patient who had a cutaneous involvement, as well as some pulmonary involvement. Clinical features of EGPA usually are divided to 3 phases: a prodromal phase, where patients have severe allergic asthma attacks, allergic rhinitis, sinusitis, and then an eosinophilic phase, where pericarditis could be involved, as we thought about in the case. And lastly, a vasculitic phase, where the cutaneous, palpable, purpura, and even neurological involvement, such as mononeuritis multiplex. Finally, such patients need to be treated with a multidisciplinary approach. And yeah, that's quite much everything we talked about today.
Thank you so much, Mohammed. I'd like to thank everyone who has joined us today, especially Dr. Abdulhadi Jfri, as well as Dr. Asma Zeidan. Dr. Abdulhadi has a clinic today, but he's actually volunteered 1 hour of his time to join us today. So thank you so much for joining us. And until another subspecialty VMR. So thank you all, and see you on another VMR.
Thank you, guys.